Okay, so I'm just getting back to where we left off. So we can use some landmarks in the mouth that we know are always buccal. They're always buccally oriented to help us when we're looking at an object. So instead of thinking about two objects and comparing them, we can compare an object or something that we're trying to figure out where it is in relation to something that we always know is stably in one part of the mouth. So for example, we can look at the variation in root lengths and the direction that the roots are pointing. We can look at the movement of the cusps and the movement of the roots in the direction that the cusps go. And this only works on premolars and molars because there's a buccal and a lingual cusp. And then we can look at the zygomatic process because that's like your your cheekbone basically. That's very buccal. That's out toward the outside of your face. And then the external oblique ridge is always on the buccal side of your mandible. So you can look at those things as stable landmarks in your radiographs to help you determine if another object is buccal or lingual. So here we go. So this is showing how changing the horizontal angulation will tilt roots. So with these three pictures, so here's central incisors, and the shot is being taken straight down the middle. And then it's hard to say mesial or distal really because we're at the midline, so it's hard to say that. But if the direction of the beam is being aimed toward the patient's left, then, because remember our right is the patient's left and vice versa, so then the roots are going to be tilted if we're looking straight at the patient, or if we're looking at the monitor, the roots are going to be tilted to the right. And then if the beam is heading more toward the patient's right, then the roots are headed in the same direction. So they basically tilt in the same direction as how you're angling the beam. Sorry, all of a sudden I'm kind of froggy. But this works in all areas of the mouth. So we know that we can look at this, we know that these are the buccal roots. This is the palatal root back here. And these are the roots that are more the mesial and distal buccal roots. And so you can see again how the roots are being tilted in the direction of the beam. So if the beam is heading off distal, the roots are heading off distal as well. If the beam is heading mesial, the roots are tilted mesial. And then if we look at the cusps, so I wonder if the next film is... Okay, yeah, the next film talks about the cusps. So when we look at a film, the cusps that are hanging down farther and are closer to the edge of the film are always the buccal cusps. So I always have thought about it as, I know that the sensor is on the lingual surface, so I always think, well, the lingual cusps are going to look higher and closer to the film. But it's actually another way of saying it too, is that the buccal cusps are always the lower ones that are going to be closer to the edge of the film. So if you look at the direction of which way the buccal cusps are going, if we use this middle one as our baseline, and we see that the cusps are kind of pointing straight down, and then over here we see that the beam was angled more distally, and now all the cusps on the buccal cusps are all sort of pointing more distally, and then over here the beam is heading more mesially, and now the buccal cusps are more mesial in comparison to the lingual cusps, which are higher up here. Down here is the buccal cusps, up here is the lingual cusps. And so the direction of the roots and the direction of the cusps follow the direction that you are pointing the central beam. Buccal cusps are always closest to the edge of the film, only works in the posterior because you have two cusps to compare. Okay, so horizontal angulation movement of buccal cusp. So if we use the cusp as our sort of guide to help us determine if an object is buccal or lingual, then we would pick one of these films as our sort of our baseline. So we can use the one that looks a little bit more kind of straight on. So we could use this upper one as our baseline. And we can say, okay, here's my buccal cusp down here. Here's our object. It looks like it's in between the premolar and the molar. So if then we jump down to this image, let's look at the buccal cusp. Does it look like it's leaning mesial or distal? It looks like it's leaning more distal, right? It's heading back toward the molars, which would be more distal. So our beam moved distal. And just to say it again, so I'm looking at my baseline buccal cusp. We know things that are buccal move in the direction of the beam. So the cusp looks like it went distal. So then we know the beam went distal. And so if the beam went distal, now we know that. So you can kind of make a note, beam went distal. So now we look at our object. The object went from being in between two teeth to, did it move mesial or did it move distal? It moved more mesial, right? So now instead of being between the premolar and the molar, it's now in front of the premolar. So our object moved mesial, our beam moved distal. Those are opposite directions, and things that are opposite of the way that the beam moves are more lingually placed lingual in the mouth. So I know that it's hard. I wish that I could kind of draw it out while I'm talking, but that's basically how we can tell if this object here, I'm losing my mouse, if this object is more buccal or lingual. We look at something that we know is stable, something that we know is buccal. So we know this. Where does my mouse keep disappearing? Here it is. So we know that this cusp is buccal. The cusp is leaning distal, so the beam was moved more distal. The object moved more mesial. So since they're opposite, the beam went one way, the object went the other, we know the object is more in the lingual part of the mouth. So, oh, and I think this slide is basically just saying angle change. So the top buccal lingual cusp of the first premolar lined up, bottom buccal distal to, oh my gosh, when I read all of this, supernumerary moved mesial, so it moved over the premolar, compare opposite of the beam, so it's lingual. So it's just kind of the answer to what we talked through. Okay, so we can look at another one here. Horizontal angulation movement of the buccal roots. So let's see. So if we take this film, let's see, works only in maxillary molars, 2 buccal roots, 1 palatal. So here we have the buccal roots here, and then we have the palatal root. And then we can also use the cusps as sort of a guide as well. So if this is our baseline image, because it looks like it's more straight on and we can see through the contacts, so we'll use this as our baseline. And we can see that the cusps sort of are leaning more mesial. And these 2 roots are sort of leaning more mesial. But what happened to the palatal root? So the palatal root went from being kind of right in between to being kind of off more distal. So if the beam was angled more mesial, but the palatal root is going more distal, that makes sense because the palatal root is a more lingual surface. We call it palatal as opposed to lingual, but it means the same thing. It's on the inside as opposed to on the outside. So 2 buccal roots, 1 palatal. Buccal roots move in the direction of the beam, so they're moving more mesially. And then the top beam directed mesial, why? I don't know what they mean by why. Oh, maybe just how do you know? Because you can tell that the roots are going this way, the cusps of the buccal cusps are going that way. So that's how you can tell that they're moving. And then the bottom is the baseline, which is what we compare it to. Okay, let's look at another one. So I think this is where they stopped and practiced, but I'm going to find the worksheets for you guys to do it at home on your own. There's a couple different examples. But then again, if we look at this, so now we're going to look at something else that we know is stable. We're going to look at the external oblique ridge so that we can see something else that is a stable buccal landmark. So if we look at the external oblique ridge, it's coming down and it comes down and it touches right about just under this amalgam filling. So the buccal external oblique ridge comes down and it ends right about there. And so we're going to use this picture as our baseline. So then if we look at the top picture, we can see that the external oblique ridge comes down and it ends way up here. So it went from down here to way up here. So it moved, you could say that it moved mesial, because it didn't move back, it moved forward and up, basically. So you can say that so that you know then that the beam moved mesial as well, because it went from way down here to way up here. So you know the beam moved mesial. So now you look at the root of this impacted third molar. This is the root right back here. And then you look at the new picture, and the root went from being pointed back here to now the root's pointed up here. So do you see how the root went from being in this direction to now being in this direction? So the root also moved mesial. So if the beam moved mesial, the ridge moved mesial, because the beam and the ridge move in the same direction because they're buccal. And then this root moved mesial. That must mean that the root is pointing out toward the buccal, and that the crown of this impacted third molar is actually facing the lingual. Now that could take a second to wrap your mind around, I realize, but I'll just say it. I wonder if I can say it a different way. But yeah, if you look, we know for sure that the direction that the ridge goes is the direction that the beam goes. So if the ridge went up and mesial, we know that the beam went up and mesial. And so we know those two things are constant. And so then if the roots had gone more distal, then we'd say, oh, the roots are lingual, but the roots went mesial with the beam and with the ridge, so they must also be buccal. Okay, and I think this might just be the talking out of what I just said. So you guys can read over that. Hopefully it kind of jives with what I said. Sometimes these abbreviated things don't come from my brain, so I don't always know, but that's essentially the angle has changed. The bottom ridge crosses distal of the second molar. Top ridge crosses middle of the second. So it goes from the bottom to the middle. Roots of the third molar shift forward from the bottom to the top. So from this bottom picture to the top picture, the roots have shifted forward. Compare roots moves in the direction beam is aimed. Root is buccal, crown is lingual, which is what we said. Okay, so now what we want to figure out is, so here we have this, our mandibular canal where the nerve runs through, and then we have these roots. So are the roots mesial or lingual, or where is the canal in relation to these roots? So the external oblique ridge always buccal to the teeth. That's a good clue. So that is something stable. The mandibular canal is highly variable location, not a good clue. So the canal starts very lingual, and then it kind of travels through, like way up at the top. It starts very lingual, and then it travels down your mandible, and then it exits out the mental foramen, which is very buccal. So the canal in itself is a very poor location device because it changes. It's in some places it's more lingual, in some places it's more buccal. So the canal is not a good landmark to use, but as we know, the external oblique ridge is, because that's always buccal. Okay, they did more practicing. We're going to skip that. So vertical movement as well does similar. You can use vertical. So we've been kind of talking about horizontal, the beam moving mesial or distal, but the direction of your vertical, the BID going more vertically up or vertically down, not just raising and lowering the BID. That's not what we're talking about. We're actually talking about tilting the vertical angulation up and down, and how that is also a way to track it as well. So in the diagram at the left, the buccal yellow and the lingual red objects of interest are superimposed on each other because the beam is directed perfectly perpendicular to both of them. So they are superimposed over each other. Both images are superimposed over the mandibular second molar. Now the operator took the BID and pointed it down. So they pointed it down in a downward trajectory. So when they did that, what happened? The buccal object moved down as well, and the lingual object moved up a little bit. So again, the buccal object moves in the direction of the beam. So if your central rays are now pointing down, the buccal object will also move down in the image. And just opposite of that, if you take your BID and you angle your BID and your central ray up, then all the central rays are going up through the tooth. The buccal image is going to move up in the image, and the lingual will move down in the image. So we can use something like the zygomatic process, which is very, very buccal. So here is a very sharp downward angulation, and so you can see how low the zygomatic process is in the picture. You can see a lot of it because the BID was at a sharp vertical downward angle. So it also brought the zygomatic process down into the image. This image is flattened out more. So now it's a little bit more perpendicular. So essentially the beam was raised up, right? It went from being angled sharply down to raising the beam up slightly to be more level. And look how much the zygomatic process lifted up out of the image. So it went from way down here to way up at the top. Here's another example. Which radiograph is our baseline? So we want to use the one that's kind of more straight on. So let's use this bottom one. And then you can see here, so here's the maxillary sinus. So the maxillary sinus and the buccal, you could look at the buccal cusps, you can look at the maxillary sinus, you can look at the zygomatic process. Everything came down. Everything came down. The buccal cusps came down, the maxillary sinus came down, the zygomatic process came down. So the beam must have been angled down. But what happened to this impacted canine? The impacted canine rose up. In this picture, it went from here to up here. It kind of looks higher on the ends of the roots there. So that means that this impacted canine is more toward the lingual than toward the buccal, because everything that we know that is buccal moved in the same direction, but our object moved in the opposite direction. So everything that's buccal moved in the same direction as the beam. The cusps, the maxillary sinus, the zygomatic process for sure is what we'd pay the most attention to. They all moved in the same direction as the beam, but our object of interest moved in the opposite. So it's more lingual. There's another practice. And let's see, what is this doing here? So this is just, again, demonstrating, I think, the vertical angulation if you're moving your beam up or down in a vertical motion. So if we look at, which one should we use as the baseline? If we use this lower one as the baseline, the external oblique ridge comes all the way down here and stops down here by the CEJ, and we can't see any of the root of this tooth. we can't see any of the root. It just looks like it circles off right here. So the external oblique ridge comes down to the CEJ. We can't see any of the root. Now in this image, the external oblique ridge has done what? It's gone from down here, it's gone from down here, like probably here-ish, to up here. So the external oblique ridge has gone up. So then we know the beam, the vertical angulation of the beam must have gone up as well. So the vertical angulation has been tilted upwards. And now we see this little faint end of a root. So here now we see a little faint end of a root. We could not see that in before. That tells me that the root is also now emerging in a more upward direction. Just like the external oblique ridge raised up, the root kind of raised up and kind of came in the same direction. So that tells me that the root is more buccal and this big crown portion is more lingual, because the root also moved in the direction of the beam. So everything came up. The external oblique ridge came up, the root came up, and the beam had gone up as well. So everything, those three things, so that helps you orient if this tooth is, which way the crown is pointing. So the crown is pointing lingual and the roots are pointing buccal. I think that's just what that says there. And so now we're going to decide how can we tell if this composite is on the buccal or the lingual. So let's use one as our baseline. We're going to use this because it's a more straight on shot. So this image is like straight through the contacts. So then when they go to take this picture, if you think about when you are, I wish I could use the camera, but it messes up the sound quality of my, it messes up the sound quality of the recording. But if you're taking a shot and you're looking straight on, and then you move your beam a little bit to get the canine shot, you have kind of angled your BID a little bit more, oh shoot, I was going to say mesial, but is it actually mesial? I think you're aiming your BID a little bit more mesial. So if you have angled your beam more mesial, and then you notice the location of this composite went from this side over to more toward the mesial as well, so they moved in the same direction, then that means that your composite is actually on the facial surface. So when you move your BID around to get your canine shot, and you're tilting it, your beam is going a little bit more mesial, you look and see that this composite moved mesial. That means they moved together in the same direction. That means that your composite is on the buccal, not the lingual. So now, let's see, so now we look at, I think there's just a couple more here. So now we're going to look at this one. This is obviously the one we'd use as our baseline because it's more of a straight on shot. You can't see that it's a bifurcated root, but here in this image, you can see these two roots. And so now which one is the buccal and which one is the lingual? So from here, the image, you can tell that from this shot, your direction of your BID actually turns more distal. So from this premolar position to swing over to this position, you actually changed the direction to be more distal. And so then you look to see, well, this one stayed the same, right down the middle, but this one moved mesial. So if your beam moved, if your beam moved distal and this canal moved mesial, that's opposite. So then this must be your lingual canal. I'm going to say that one more time. So if you compare your premolar image to your canine image and you think of how you move your whole entire beam when you're going from a premolar to a canine shot. If you're going from a premolar shot to a canine, you're swinging your beam a little bit more distal. So if you've moved your beam distal, but this canal is tilting mesial, those are not the same, those are opposites. One's going distal, one's going mesial. So then you know that this is your lingual because it moved in an opposite direction of your beam. I hope that makes sense. These are not easy, you guys. I will definitely not be the first to admit that they're easy. I'll be the first to admit it's a challenge. That's what I want to say. It is a challenge. Okay, so this is kind of a little image. When the beam is moved distally, the two canals, which were initially superimposed, premolar periapical above, will separate, and the buccal canal, which is the blue one, will follow the beam movement, so it will go more distal, and the lingual canal will come more mesial because it's going to come in the opposite direction of your BID. See how you're back here and you swing your BID over to take your canine shot, so now your beam is pointing a little more distal. Separates the two canals so you can see them. The one on the lingual goes the opposite direction of your beam, so it goes mesial, your beam was pointing distal. And this was a great little thing that I don't even know if I knew this trick, and so I'm interested to try this out in clinic when we have an opportunity, which I'm sure we will. So this is something that Holly talked about. So how does all of this kind of help in some real world situations with moving the beam and getting different images? So she was talking about how often in clinic you'll get patients that have very small mouths, and no matter what you do, you can't get the sensor back to center over the second molar because their mouth is just too small. They have a shallow palate, they just have a tiny oral cavity in general. And so how can we use these tricks of moving the beam in different directions? So here is an image where this is the second molar, but the mouth was just so small, there was no way to center this film because you couldn't get the sensor back far enough. And so here's another image of, here's the second molar, and there's a third molar back here that they need to get. So not only do they want to get more of the second molar, they want to get some of this third molar, but the patient's mouth is so tiny, and you can't just always say, I'm just going to take a pano on everybody, because for one, that's a lot of radiation to take a full mouth series and then on top of that take a pano. Do we do it sometimes? Yes, we do it sometimes, but should we just have that be our answer for every single person who doesn't want a sensor or can't handle a sensor in the back of their mouth? No, we shouldn't. So this I thought was genius, and I can't wait to, like I said, try it out. But they kept the sensor in the exact same spot. So they didn't move the sensor back any farther. But what they did do is they took their BID and they moved it a little bit back and then angled it more mesial. So they took it back farther and then turned the vertical or the horizontal angulation more mesial. And doing that, they still covered the whole sensor. They got a lot of horizontal angulation error, and they got foreshortening. You can see things are very, there's distortion here, but you can see the whole tooth and you can see the apices. And so that, is still better than having to expose the patient to a whole full mouth, bunch of retakes, and then a pano on top of it. So we'll try this out when we can try it on Dexter, or we'll try it when you have an opportunity with a patient with a small mouth. You leave the sensor as far back as you can get it, and if that is not anywhere near centering the second molar, then you just get it back as far as you can. You push your BID back, and then you angle it more mesial so that you're covering the sensor. And then, we'll see if it works. I'm very excited to try it out. So all right, that is location techniques. I hope that made some sense. We're going to just do some worksheets and practice the rule, and hopefully the more you do, it'll become clearer and clearer. All right, see you guys later.